1. We are live now.
Good evening to all our viewers of OrthoTV. A warm welcome to you all. We are here with the third episode of the second season of series and controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with an interesting case presentation followed by discussion in each subspecialty of orthopedics. This session is dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with the goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeons to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Professor S.S. Mohanty and Secretary Dr. Ashish Phadnis, Dr. Swapnil, Keny, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SECGS Medical College and KEM Hospital, Mumbai. He is an honorary consultant at Jaslok, Nanavati, and Susrita Hospital. He is the past president of Bombay Orthopedic Society, an academician, and a researcher. Today, we have three brilliant young orthopedic surgeons, one each in trauma, spine, and pediatric orthopedics, with an expert panel including Dr. Nitish Arora, Dr. Tarun Suri, and Dr. Ankit Khurana. I would like to call upon Professor Mohanty sir to introduce our presenters and proceed with the session. Dr. Mohanty sir, all to you now.
Thank you, Deepak. Good evening, dear friends, and greetings from Mumbai. Welcome to the third episode of the second session of Controversies and Consensus in Orthopaedics. Today, we have three subspecialties, trauma, spine, and pediatric orthopedics, and three young orthopedic surgeons will be presenting the cases, and we have three expert panel from different parts of the country to moderate this session. Now, let me introduce the first panel of experts, presenter and the expert. So our first presenter in trauma will be Dr. Ritwika Nandi. She is MS Orthopedics from NRS Medical College, Kolkata, and at present working as assistant of professor at Institute of Medical Sciences, Shyam Hospital in Bhubaneswar, Odisha. She has done her fellowship in arthroscopy and arthroplasty in IOA IAS, IAS Gopal Krishnan, and ISCA fellowship as well. Welcome, Ritwika, for this interesting session, and we are looking forward to hearing from you.
Thank you so much, sir.
Now we have expert in this trauma session is Dr. Nitish Arora, who after completing his MBBS from Nair Hospital, Mumbai, pursued his MS Orthopedics at PGI Mirrors. He is at present a consultant pediatric orthopedics, complex trauma and reconstruction, as well as a pelvic surgeon in Medicover Hospital at Kharghar, Navi Mumbai. He finished his senior residency at All India Institute of Medical Science in New Delhi, and then pursued a pediatric orthopedic fellowship with Dr. Matthew Varghese and Chacha Nehru Bal Chikitsalayah at New Delhi, and followed by Assami fellowship with Dr. Mangal Parihar from Mumbai. He is a AO faculty and Assami faculty. Thank you, Dr. Nitish, for joining today, and thank you for your time in moderating this session. Now let us go ahead with the presentation on trauma from Ritwika. I'll stop sharing the screen and welcome Dr. Ritwika to share her screen and present the case.
Am I audible, sir?
You are audible and visible.
Thank you, sir. Thank you to all my encouraging seniors and colleagues for this opportunity. So my case is a bilateral asymmetric hip dislocation case. A 30-year-old male presented to our OPD with a history of RTA 17 hours back. Because the patient was referred from a tertiary center, we got the patient after he was resuscitated. Then he was sitting in the passenger seat of a truck. So his right foot was on the dashboard and his left foot was in an left leg was in an extended position. And this was the X-ray we got, the radiograph initially. As we can see, there is a right-sided anterior hip dislocation and a left-sided posterior hip dislocation. We, under sedation in emergency, we reduced both the hips, and this was the post-reduction radiograph we got. Because of the posterior wall fragment we saw on the left side, we got further CT scans and evaluated the patient further. Now, bilateral hip dislocation simultaneously is very rare in literature, about 0.01 to 0.02% of all the joint dislocations that present in our practice. Evaluation is very important because of the high energy nature of this injury. It is more often than not associated with another fracture. More commonly, acetabulum in the posterior dislocated hip as seen in our case, but also there is often femoral neck fractures or other fractures of the limb which is affected most. Early reduction within 6 hours is definitely the mainstay of management because as in any other case of hip dislocation, we want to prevent avascular necrosis. Sadly, in our case, there was already a late presentation and we tried to reduce as soon as possible. This is one of the biggest literature reviews we found, which had 104 of such cases computed. So most common is definitely an RTS followed with a fall from height, the mechanism of injury for such a presentation. Definitely with the onset of increase in the number of RTA, the number of such cases have also been on the rise recently. Most cases have been reduced with an initial management, close reduction under sedation. In our case, because of the posterior wall fragment, we planned to go ahead with fixation of that side. We used a Cocker-Langenbach approach. After proper approach, we reduced the fragment and used 2 spring plates to hold the fragments in position. Further, this is a post-op radiograph, and this is the patient. Now, currently 3 years post-op, and definitely there is definite avian, but the onset of avian, but he has resumed his work. He's not willing for further investigations at this point or any further surgeries, and he has gone back to perform his activities of daily living, and he's satisfied for now. But definitely we are keeping him under follow-up because there will be further progression of that side. The other side, we just kept in traction for around 3-4 weeks, and then we started range of motion. Thank you, sir.
Excellent case. Actually, first time I'm seeing a bilateral hip dislocation where one side posteriorly, one side anteriorly.
Can you see
dislocated.
the dislocated X-ray, please?
Yes, sir.
Give the slide. Flat. So it was referred as it is, only after resuscitation without reduction, right?
Yes, sir.
Very good. So left side nerve is okay?
Yes, sir. Thankfully, it was fine.
Okay.
So,
sir, Dr. Nitish?
Which side you reduced first?
So we reduced.
Is there any rationality of reducing this side first or that side first? And which position did you reduce? Can you just elaborate a little bit for the benefit of the viewers?
Right, sir. We started with posterior side because it was more easier in that way. If once the posterior was reduced, we would have thought we would deal with the anterior one. We used a classic Ali's maneuver. We put the patient on the ground because that was the most way to get access to the patient because we needed multiple hands in this case. So we had the patient on a gurney on the ground. We first used the Ali's maneuver to reduce it. And then the anterior side was relatively easier because we just applied traction with lateral pressure and it reduced comparatively easier than the other side.
And in the city, there was no fracture on the right side.
No, sir. No, sir. The other side, there was no fracture.
Okay. Okay. Over to Dr. Nitish.
Thank you, sir. Thank you for opportunity. Thank you for giving me the opportunity to be a moderator in this session. I think Dr. Ritwika has presented a very good case. This was one of a rare kind of case, which bilateral dislocation I have never seen. Right side was okay, but then left side, Dr. Ritwika, I have just few questions. First thing is, this was a posterior superior wall fragment. I think I'm right.
Yes, sir.
This was a superior. So did you ever thought of pre-operatively of doing a trochanteric flip osteotomy? Pre-surgically, did you planned it? Or
Yes, sir, we planned for every alternative and we took the decision intra-op ultimately.
okay, so were you able to reach to that fragment without the trochanteric flip osteotomy easily? Because it
Yes,
is
sir,
a very
because it
high
was,
fragment. It's a very
yes,
just over the top of the acetabulum. It seems to be.
but
So
the fragment was very lateral off. On after exposure, it seemed pretty lateral off. So we
so
could get it without doing a flip osteotomy.
so you were able to reach to that fragment without doing a trochanteric flip osteotomy. So which
Yes.
maneuver did you did for reaching to that fragment? Did you abducted the limb during surgery?
Yes, so we generally abducted the limb in when the initial
Consistently.
part of the surgery. We abducted the limb in the lateral position to help in the reduction.
So that was without osteotomy, you were able to. And one more thing, you applied only the spring plates. You could not, you did not buttresses those like spring plate by putting a recon plate over those spring plates. Did you thought of it or
Yes, so
you
we
thought
thought
it
of
is?
it. But so actually the fragments were very lateral. So we thought the spring plates in itself would not add, like in this case, we would have to expose it further and probably do a flip osteotomy to get access to the superior screws in that case. So we thought because the stability was kind of good after putting two spring plates, so we left it at that. But definitely a secondary plate would have been more stable in
So,
such cases.
you just open the immediate post-op X-rays. You've done a wonderful job, but then I think only spring plates would not be just stable enough to provide a stable reduction. If you would have put a one-third tubular plate or a simple buttressing plate over those spring plates, would have made your reduction much more stable. Did you thought that this reduction might have displaced in the immediate post-op period?
Uh, Definitely a percentage of it, but it wasn't enough for us to go back with a
But yes,
second.
for that extra buttressing, you need a trochanteric flip osteotomy because you'll not be able to put. And anyways, you got a very good results. Congratulations. And
Any post-operative traction did you give after fixation
No, sir,
in
not
order
on
to
this side,
prevent?
not on the left side. We did on the right side because it wasn't operated.
Okay. And yeah, yeah,
you
Nitish.
did a lateral position or posterior position? Lateral position?
Lateral position, sir.
Okay, nice. Good.
Very well
Just
managed,
to add,
Dr. Nitish. I think very apt comments that you've made in this particular case, and even I also feel that once the spring plates are in, it's always better to put a recon, right, buttressing the posterior wall. So getting that sort of construct gives more stability to such fragments because I feel that with the plates that are in and the number of screws that are there, it looks slightly unstable, although I think the operating surgeon would have a better idea intraoperatively.
Just one screw in a spring plate doesn't make it much a stable
Construct. I agree with that. I agree with that. Although I think the operating surgeon might have had different views.
Yeah, but she knows introp conditions.
Definitely.
Yes.
one thing, Ankit, you are there, na? Since you are reading those books of FRCS, there is still one question. If dislocation you reduce, what is the next thing you should always do?
So CT scan and traction would be the
Answer. Whether there is a fracture or not, after reduction, the first thing you should do is you should always confirm with the CT scan.
that's true.
So you told Nandi there was a fragment there. Even if there was not a fragment, you should always do a CT scan after reduction.
Always.
Understand?
So anterior hip dislocation, I would just like to ask the presenter. I mean, you said that you were really lucky to get an easy reduction out of it. I mean, there are times when anterior dislocations have to be converted to posterior dislocations and then reduced by the Alice maneuver. That is also, something that I have seen, especially with the obturator type anterior dislocations. What is the view of the house on that? Do they find that it is easier to reduce? Because I've had a lot of trouble in reducing those.
Yeah, I think anterior dislocation is more difficult to reduce compared to
That's
posterior
true.
dislocation.
That's true.
And we see very less of anterior dislocations. Earlier, I have seen two and one neglected anterior dislocation, which you had seen. But having said that, they could reduce it. Did you reduce it under anesthesia, correct?
Yes, sir. Yes, sir.
They
Under
gave
sedation.
anesthesia. Okay.
Yes, sir.
Mhm.
So they reduced it under anesthesia and
Anesthesia.
it came out to be stable and there is no other fractures. So
So
at
there are
least,
times when
yeah.
you have to convert it to posterior by bringing it at the back and then pulling it in front. So those are maneuvers that are described, and I find them rather easier than rather than putting the anterior dislocation right back in, because it is very difficult to get that done. It is easier said than done to directly reduce it. But I think the team there probably had a different experience altogether.
But any of us have seen such kind of windswept type of dislocation on
Bilateral.
poster? We have never
Asymmetric.
seen. I think I have never seen you.
Yeah, I have seen bilateral dislocation, but the bilateral posterior dislocation was there.
Bilateral
only.
posterior.
Yeah.
Bilateral
Bilateral
posterior.
posture we have seen, but this
But not-
windswept type we have not seen.
So this was typical obturator type of anterior dislocation, bookish picture, sir.
Yeah.
Mhm.
I think Ritwika, you must publish it in the Journal of Case Reports. At least in Journal of Case Reports, you can publish it.
VOCR.
It's a good.
Yeah.
Yes,
And
Have you published this case?
yes, I just published it last year.
Right.
okay. You have already
Should have
published.
made a
Very good.
separate slide of that. Anyhow,
You should have.
okay, let's move on to the second speaker. Yes, sir?
Yeah. Having said that, success cannot be challenged. So we agree, all of us agree that we should have there should have been another buttressing plate along with the spring plate in order to reduce this fracture. But looking at the results and all, it has worked out well with Ritwika. So congratulations to you, Ritwika, for an outstanding result.
Thank you.
Now you need to prepare for hip replacement on the left side. Okay. So good. So let us move to the next, presentation. So next presentation will be related to the spine, subspecialty of spine, and we have with us Dr. Abhishek Anand, who has completed his MBBS from All India Institute of Medical Sciences, Patna in 2022, and now pursuing his post-graduation in the same institute, All India Institute of Medical Sciences, Patna, and in the final year, and doing a dissertation under the spine unit. He has presented papers on clinical radiological comparison of pooled versus clinical radiofrequency ablation in discogenic pain in patients at Bihar Orthopaedic Association Conference 2024, and had a poster presentation on post-traumatic kyphotic deformity at second ASDC, All India Institute of Medical Sciences, New Delhi in 2023. So welcome, Dr. Abhishek, for your case presentation, and thank you for joining with us.
Thank you, sir.
Yeah, and with us to moderate Dr. Abhishek's case, we have Dr. Tarun Suri, who is MS DNB and completed his fellowship of National Board in Spine Surgery. He is at present a senior consultant and head of spine surgery at Amrita Institute of Medical Sciences, Faridabad. He was the professor and senior spine surgeon at Maulana Azad Medical College, Delhi. He is AO Spine India Delegate Council member, and he's also an executive council member and education committee and research committee member of Association of Spine Surgeons of India. His special interest includes spinal deformity and minimally invasive spine surgery. He has 30 index publications and 6 book chapters. Thank you, Dr. Tarun, for joining today and devoting your time for the cause of academics. Thank you.
Thank you, Dr. Mohanty. Thank you, Dr. Deepak, for this wonderful interaction. And great case, Dr. Ritwika. I'm looking forward to the spine case now.
Now, Dr. Abhishek will be presenting. Yeah, Dr. Can you share your screen?
Yeah, yes, sir.
Avinash, I'm sorry, Dr. Avinash Kumar.
Yes, sir. I'm Dr. Abhishek Anand. Are my slides visible, sir?
Yeah.
Yeah.
Okay, sir. I will be starting the presentation. Yes, please go ahead.
You can click on the
So,
lower left-hand corner in order to proceed. Yeah. Okay.
Today I'll be presenting a case of unilateral biportal endoscopic spine surgery, who on post-operative day presented with abdominal distension, immediate post-operative. We had a case of 61 years male who presented with lower back pain relating to bilateral lower limb for 5 months. Patient had history of similar symptoms 2 years back. The pain of the patient exaggerated on flexion, and there was no history of any trauma present with the patient. There was no any history of any comorbidities in the patient. As you can look at the MRI of the patient, there is evidence of facet arthropathy present at L4 and L5 level. Also, there is protrusion of disc towards the left side. Can be seen towards the left side. So we planned him for endoscopic TLIF surgery, and the duration of the surgery was 3 hours. We used 2 ports. The camera port was on the left side, at the level of the upper wall of the L4 pedicle on the lateral pedicular line, and the working port was at L5 pedicle on the lateral pedicular line. Continuous water flow system, only gravity based, and no any pump system was used, which was placed 1 meter above the ground, was used for the surgery. Discectomy was performed from the left side after removal of the articular processes. Disc space was prepared by shavers and curettes, and anterior disc space was packed with graft. Cage was inserted on the disc space, confirming its position under image intensifier. After the confirmation of the position of the cage, pedicle screw fixation was done using MIS and bilateral sites, and the position of the hardware was checked under image intensifier. Post-operatively, the following situation happened with the patient, that severe abdominal distension was observed in the patient, and the blood pressure of the patient, we couldn't control the blood pressure of the patient. It was continuously high to 180 to 100, 180 by 110 mm of Hg on an average. And pre-operatively, the average value of the blood pressure was almost 120 by 80. The urine output of the patient, including the 3-hour duration of the surgery and 2-hour post-operatively, was less than 20 ml. And the serum lactate of the patient was also was elevated immediate post-operatively. It was almost 8 millimoles. Bowel sounds were absent after checking post-operatively, and the patient hadn't passed status till 4 hours of surgery. So looking at these situations that happened with the patient post-operatively, what are the differentials? What we thought that while preparing the disc space, some major vessel injury might have happened, or some traumatic aneurysm of the large vessel might have happened. But these cases should have been led to fall in the blood pressure. However, in our case, the patient continuously presented with an increase in blood pressure. We could also think of paralytic alias. For that, we took certain measures. We immediately post-operatively we inserted nasogastric tube and Prater's tube. However, no symptomatic relief in abdominal distension was seen. We could also think of abdominal perforation, but it would also lead to fall in the blood pressure, and no any other symptoms like nausea, vomiting, or any abdominal pain was present in the patient as such, which could be localized. So on performing ultrasound thorax, fluid was noted in the abdominal compartment, which was documented to be 800 ml. And we performed a diagnostic tap, and normal saline was excavated out. So this was the condition of the abdomen of the patient immediate post-operatively, and we performed a diagnostic tap to look for what we could achieve. So retroperitoneal excavation of we finally thought that retroperitoneal excavation of the fluid might have happened intraoperatively, and this would have the fluid leak into the abdomen would have caused the distension of the abdomen and would have led to acute intra-abdominal hypertension. This hypertension would have further compressed the renal vasculature, which have led to decreased renal output, and further compression over the aorta and the vena cava would have led to increase in the peripheral vasculature, resistance of the peripheral vasculature, which have led to increase in the blood pressure. So what are the measures that we took in our case? First of all, immediately nasogastric tube and flatus tube was inserted to rule out any of the paralytic ileus cause or any other common conditions which might happen post-operatively in the patient. Therapeutic ascitic tap was done, which led to drainage of 200 ml of fluid. And we gave furosemide 10 mg BD for the patient to the patient for continuous 5 days. And while this period, regular electrolyte was measured in the patient. Serum lactates were checked daily for the liver function. Patient was under constant observation in the ICU room for blood pressure monitoring and any pulmonary complication which might happen to the patient during this period of time. Abdominal girth of the patient was also kept under check continuously during this time period, and bowel sounds of the patient was also checked continuously. We kept a continuous observation of the abdominal girth of the patient to confirm that the symptoms are subsiding. We also got a CT scan of the abdomen to confirm that the fluid collection around the abdomen was located bilaterally around the kidney, as you can see in the CT scan here. So this was a case of, we had a case of acute abdominal hypertension post endoscopic supine surgery, and we had 2 or 3 such papers which reported reported a similar conditions here. Here is a paper which led to that 2 patients complained abdominal pain immediately after surgery. A post-operative CT scan abdomen revealed a fluid collection in 1 patient. Abdominal pain resolved completely on conservative management in both of these patients. And here is another paper which presented with a similar retroperitoneal hematoma. However, here in this case, it occurred with percutaneous endoscopic lumbar disc surgery. So abdominal compartment syndrome, normally intra-abdominal pressure is normally up to 5 to 7 and with the upper limit of 12. Intra-abdominal hypertension is usually defined as when the intra-abdominal pressure rises to more than 12 mm of Hg. Intra-abdominal compartment syndrome is said when there is sustained increase in the abdominal pressure to more than 20 mm of Hg, which led to a new organ dysfunction. These are the effects of the abdominal compartment syndrome, as the abdominal compartment syndrome could affect all the other organ system in our body, including the central nervous, the thoraco-abdominal, hepatic, gastrointestinal, the cardiovascular, and the renal system. So the telltale signs in our case was we had an abdominal swelling post-operatively. So the differentials which came into our mind was aneurysm, major vessel injury, abdominal perforation, or ileus. However, all of these cases would have led to fall in the blood pressure. However, in our case, we had an increase in the blood pressure of the patient. Increased serum lactate levels were because of direct hepatobiliary compression, which decreases the hepatic outflow and thereby decreases the clearance of the serum lactate. Delayed passage of the flatus, direct compression over the gastrointestinal tract may lead to reduced GI motility and inhibit the flatus passage. And we also had a decreased urine output. Direct renal compression would have led to decrease in urine output of the patient. However, we can't wait post-operatively to confirm that the patient is having certain complications. If we can find any sign that we can find intraoperatively, which would suggest that such a condition might have occurred in the patient, then it would have been better. Looking into this, we had an intraoperative marker which happened in this case. On insertion of the funnel into the anterior disc space for grafting, we had a gush of the fluid coming out through the funnel. And this probably wouldn't have happened because on the insertion of the funnel, this fluid might have probably been the retroperitoneal fluid. This gush of fluid which came out from the retroperitoneal space might be a red flag which indicate a breach in the anterior longitudinal ligament and damage to the retroperitoneal membrane. So the take-home message after looking at this case is, while shaving disc space, care should be taken not to breach the anterior longitudinal ligament, and gush of fluid through the funnel should be considered as a marker for the retroperitoneal membrane damage. And in case of fluid through the funnel, if we get the sign that intraoperatively that the fluid is coming out through the funnel, we should turn off the water source immediately, and we should means we should allow all the endoscopic fluid which has gone into the retroperitoneal space to come out so that post-operative complication could be minimized as far as possible. This is the patient post-operatively on POD3. POD3, the symptoms, most of the symptoms which occurred during the intra period had subsided, and this is the video of the patient post-operatively. Thank you.
Thank you. Thank you, Abhishek, for an excellent case and a new term, what I learned to the abdominal compartment syndrome. And you have nicely presented the case as well as the how to, detect it intraoperatively and how to manage it also intraoperatively. And you have managed it nicely in the post-operative period as well. Yeah, over to Dr. Tarun.
Yeah, very nice presentation. Very dangerous complication, which I think you managed pretty well and were able to come out of it. But at the hindsight, what do you think were the causes of this complication happening? I mean, while doing the shavers, did you feel that you violated the anterior annulus or ALL in some way?
Yes, sir. That might have been the that might have been happened that ALL membrane had been damaged, and moreover, on going further, also the retroperitoneal space would have been further breached while shaving most of it.
And basically, UB surgery, we all know that it's a very rapidly evolving technique being adopted by most of the spine surgeons. And hydrostatic principles have a lot of role to play in understanding and execution of the surgery. So, can you just elaborate as to how this hydrostatic principles they help in UBE, and what are the guidelines? How do we measure and monitor the pressures, and what are the other possible complications which can happen because of improper pressures in the surgery?
Sir, the major if we can get a continuous flow system through the spine with a continuous outflow with a constant pressure pump system. This is the basic guidelines which regulate that we should create a flow space with continuous flow, with a continuous outflow and a continuous pressure pump. The major complication that can happen because of this is we could have a the pressure over this could lead to create a pressure over the cord while we expose it completely, and could lead to nerve root compression as well as cord compression, which means lead to sensory paresthesias post-operatively for a few period of time.
So you're right. Basically, hydrostatic principles governed by the Pascal's law, they are used in surgery for hydrodissection for better clarity and visualization of the neural structures. The use of a pump elevates the pressure and gives us a better hemostasis. But it is also a little bit dangerous to use the pump, because if the pressures are higher, they're not regulated. That can lead to compressive symptoms. It can lead to more fluid extravasations. It can lead to spinal cord compression if you're operating high above than the lumbar spine. And there have been some case reports of ocular injuries, reports of increased internal pressures because the pressures get transmitted along the CSF flow system and disturbing the dynamics. So, in your case, how did you monitor, or how did you control the pressure, of the fluid that you use?
We earlier used to use a pump system, but rather than going for the pump system, we just elevated the source of the water to 1 to 1.5 meters above the ground to have a continuous flow. And whenever necessary, we get a pump whenever to get a more pressure. Otherwise, we don't use any pump system. We just have.
I think that's a much safer approach which you followed. Instead of the pump, let the gravity assisted hydrostatic pressure give you the clarity, and if required, you can use the pump. And what I would also like to add is that in the steps where you don't require a clear-cut visualization, such as end plate preparation and shaving, you can intermittently close the irrigation so that excess fluid does not seep in, especially after seeing such a complication where it could have been much more severe, and then it could have been much more catastrophic. So I think nicely managed case and a great lesson to all the budding endoscopic surgeons, that simple thing like a saline, which we routinely use as orthopedic surgeons in arthroscopic and now in UBE, but it can have a major complication because you are operating around vital structures. Just like a simple discectomy, you can violate the anterior annulus and ALL, and it can lead to a major catastrophic vascular injury. So, great lesson. Keep monitoring under the C-arm whenever you are close to the anterior annulus or the ALL, that you are not violating the same. Also, you also use percutaneous screws. I would also like to just tell that the guide wires used for percutaneous screw insertion, they're also a little bit dangerous. They can also violate the pedicles and lead to a breach in the anterior vertebral body. And just close to that lie the great vessel. So that could also have been one of my differential diagnoses, that I might have injured the great vessel while percutaneous screw insertion. My guide wire would have slipped, and that could have led to hemoperitoneum. So that is also something which comes in the mind, and that is much more difficult to handle.
Yes.
So newer things, fancier things, but important to stick to the steps, stick to the basics, because complications if like this, if they happen and you don't know how to manage them, then it can be very disappointing to the surgeon, and of course medical legally issues are created. So great case, Dr. Abhishek. Nice presentation.
Yeah, can I ask one question? How do you measure the abdomen compartment pressure?
So we don't measure here the abdominal compartments pressure. We basically we don't measure here to diagnose the case. However,
No, you showed in the literature that
we
if it is
showed-
more than 12, then you suspect increased abdominal compartment pressure. Like in the limb compartment, we put some needle and connect it to manometer and all these things. We measure at more than 30, then it could be compartment syndrome. Is there any way to measure? Dr. Tarun, you can throw some light on this.
We have no idea, sir. Regarding this is a very rare complication which I have also seen for the first time, and I think it's more of an academic exercise. Intra-abdominal pressure. Maybe general surgeons, abdominal surgeons would be much more aware. But I think Abhishek just put the slide to educate us that what this increase in pressure can lead to. It's very difficult to actually measure it. Of course, the most common differential, which I would have also thought, is a vascular injury or paralytic ileus, which would have happened. Very rarely think that this kind of extravasation can lead to abdominal distension and abdominal compartment syndrome.
But one pertinent point which one must suspect that whenever there is a increase, there is a tense abdomen or there is a abdomen which is distended, but there is hypertension instead of hypotension. That is what he pointed out. Then you suspect this fluid extravasation or something else other than the vascular injury. Because if there is a vascular injury, there will be hypotension. Correct?
Yes.
So that is the differentiating feature here in this particular case, and one must remember, keep it in this mind. That is a good learning point here.
Avinash, you found this complication, you noticed it 4 hours after the surgery, right?
No, Deepak, immediately we found it that abdomen distended.
So when the patient was made supine, right?
Yeah, when made supine, when patient went to post-op, just when post-op, then I got a call that patient has a hypertension and distended abdomen.
So were there not any signals during the intraoperative period, any monitor changes, anything, nothing, no signal?
No, intra-op, no vitals were deranged, neither BP nor heart rate.
In
So
fact,
I think when it was closed, then the closed compartment got a closed compartment and then BP shoot up.
Oh, right.
And one of the markers which they showed
I think the take-home message is that if you are getting an abdominal compartment syndrome, always first hand do a ultrasound, and if you find a fluid, do a diagnostic and therapeutic tap.
Avinash, you can come in the video. Avinash, you can come in the video.
Yeah.
Dr. Avinash is the Associate Professor of Spine Surgery at AIIMS Patna, sir.
Oh, okay, welcome, Dr. Avinash.
Thank you, sir. So what I think that if you are suspecting a hypertension with acute abdomen distension, you should always get an ultrasound as early as possible, and you should do a diagnostic and therapeutic tap. As soon as the pressure will be relieved, everything will come normal. So
Okay.
therapeutic type is the best thing to do for such patients, not to kill time in other diagnosis or in investigations.
Yeah.
Great, good, very nice case.
I still remember one of our residents was doing a intertrochanteric fracture, and the guide wire which he put has pierced, had gone medially, and it has torn the antennal iliac vein. And immediately after surgery, when the patient was taken out, we saw the abdomen distended, but there was hypotension. Then that time, then we did of course, ultrasound and all diagnostic tap. Then it was opened and it was repaired. Patient couldn't be survived. But as Dr. Tarun was telling, guide wires can cause the vascular injury. So anyway, the guide wires, over enthusiastic advancement of the guide wire can cause vascular injury. But you can publish this case also. Have you published it, or?
No, sir, this happened just 1 month back. We are publishing in European Spine Journal. We have sent it.
Yeah. It's a very rare case, and it's also a learning point, and you could educate us about this rare complication. Thank you very much. Thanks for presenting this case and devoting your time towards academics.
Thank you, sir.
Can you please stop sharing your screen? Now, our third case is related to trauma. And I'm sorry, pediatric orthopedics. And case will be presented by Dr. Nitish Bikram Deo, who is MS Orthopedics from Jipmer Pondicherry and is a gold medalist in the MS examination. And at present, Dr. Nitish is assistant professor in pediatric orthopedic and hand surgery unit at Tribhuvan University Teaching Hospital, Institute of Medicine at Kathmandu, Nepal. He has finished his fellowship in pediatric orthopedics at Rainbow Children Hospital and Chacha Nehru Bal Chikitsalayah at New Delhi. And he was also Pediatric Orthopedic Society of India Professor K. Wilkins Inland Traveling Fellow, visiting Wadia Hospital in Mumbai and Ganga Hospital in Coimbatore. Dr. Nitish has 6 publications to his credit and is a member of Pediatric Orthopedic Society of India, Nepal Orthopedic Association, and Pondicherry Orthopedic Association. Welcome, Dr. Nitish, and thank you for joining today here in this session to present a pediatric orthopedic case. And to moderate, we have, Dr. Ankit Khurana, who is MBBS from Maulana Azad Medical College and MS Ortho from PGI Chandigarh. And he has done his Diplomate of National Board and MRCS Glasgow and FRCS in Trauma and Orthopedics. He is at present Assistant Professor in Orthopedics at Dr. BSA Medical College and Hospital, Rohini. He has over 40 indexed publications and numerous national and international presentations at various conferences. Welcome, Dr. Ankit, to this episode of Controversy and Consensus, and thank you for joining to moderate this case.
Thank you, sir.
Now I have stopped. I have stopped sharing the screen, and over to you, Dr. Nitish, to share your screen and present the case.
Thank you very much, sir, for this kind introduction. Sorry, is my presentation visible?
Yeah.
Okay. So, good evening, everyone. So, I'll be presenting on ankle valgus deformity correction, which is secondary to isolated congenital pseudoarthrosis of the fibula with neurofibromatosis 1. So, I'm currently based in Kathmandu, Nepal. I'm assistant professor in pediatric orthopedics and hand surgery unit. So before moving to the case proper, I'm just introduce the case. So unlike the congenital pseudoarthrosis of the tibia, congenital pseudoarthrosis of fibula is rarer. But unlike congenital pseudoarthrosis of the tibia, it is less deforming. It is comparatively easier to treat, and it has a lesser morbidity when compared to the tibia. It often presents with a progressive ankle valgus deformity, more so when the distal fibula is affected. Till now, only 40 cases has been reported without involvement of the tibia simultaneously. And although various treatment modality has been discussed, but it's not well established yet. So there's a 5-year boy with a progressive ankle valgus deformity. He was initially treated as suspected trauma elsewhere, and he was applied plasters in spring. But again, after 10 months, the child presented with ankle valgus deformity and mild pain and prolonged walking on the medial aspect of the foot. So he also had a cafe outlet spot. His father has a family history of neurofibromatosis 1. He presented with left ankle valgus deformity, but the ankle range of motion was full. There is no other deformities like in spine. The X-rays showed pseudoarthrosis. Like in the X-ray, you can see there is a pseudoarthrosis in the distal third of the tibia. There is ankle valgus, and there is higher stationed fibula. So the fibula is stationed higher. You can see the talus is tilted laterally and shifted. This is the normal side. There is also a procurvatum deformity. If you see the station of the fibula, it is in grade 2 Malhotra grade. Clinically, you can appreciate ankle valgus deformity. There are several cafe outlet spots which are more than 5 mm. So what is the role of the fibula, and how whenever one side or one strut of the leg is absent, how the deformity happens? So in case of fibula, whenever there is discontinuity of the fibula, because of the anti-gravity muscles and posterolateral muscle, bulky muscles, and the weight transmissions, the talus starts to tilt laterally and shift laterally. The fibula goes up, and there is also secondary changes like there is wedging of the distal tibia epiphysis. And because of all this force, whenever the one strut of the couple is not working, then there is a progressive deformity which happens in the tibia as well, which is similar to congenital pseudoarthrosis of tibia, where anterolateral angulation is seen. So this phenomenon of deformity has been published by me and Dr. Anil in JPO 2023. So looking at the problems of this case has a pseudoarthrosis. It's not a traumatic pseudoarthrosis, it's a congenital and associated with neurofibromatosis. So which whenever there is association with neurofibromatosis, there is likely that there is hematomatous tissue. So whenever reconstructed or whenever osteosynthesis is attempted, it might get resolved. Another problem is there is ankle valgus deformity, which is progressive. The age is 5 years, so the child physis is wide open, and there is high distal fibula station. So how to tackle each problem? So the strategy that we discussed were, so since there is high chance of resorption of the pseudoarthrosis whenever the bone grafting has been done, so we plan to excise the pseudoarthrosis. Then to correct the ankle valgus deformity, we choose to do the growth modulation as the physis is wide open, and there is a progressive deformity, so that we can do overcorrection instead of any osteotomy. And there is another problem of higher distal fibula station, so there is always chance of recurrence even after correction of the deformity. So our strategy was fusion of the distal tibia and fibula. Various other techniques has been tried, like along with the deformity correction, people have attempted to do the osteosynthesis of the fibula. The results are varied. Some had a resorption of the case, some had recurrence, some had well-corrected deformity, which was with no recurrence. So we went to the literature and found the similar case reports, which was first published by Dr. Langenskiol in JVGS in 1967. So he applied the same. He applied the principles. So the procedure is named after Dr. Langenskiol. So what he did was he opened up the fibula from lateral side, and then excised the distal, the non-pseudoarthrotic segment of the distal third of the fibula. And instead of using the bone graft from the fibula, which is again a pathological tissue, he used the bone graft from the iliac crest with a strut, and then just around 1.5 to 2 centimeter above the distal fibular physis, he made a crest. He made a shelf which was inserted into the distal third of the tibia, well above the physis and well above the syndesmosis. So the plan was to fuse the distal tibia and fibula. As the growth rate of the tibia and fibula is similar, so the fusion won't affect the growth later on. The principle of similar growth was applied here. So we did the same procedure. We excised the pseudoarthritic segment. We followed the plane of soft tissue and then raised till the normal bone bleeding was seen. So we excised both the proximal and distal. En bloc excision was done, and then we entered through the same incision. Through the same approach, we reached the distal third of the tibia, and then we elevated the periosteum, got the harvested bone graft from the iliac crest, and just above the physis, around 2 centimeter above the distal fibular physis, we in the metaphysis region we applied the bone graft and inserted into the distal third of the tibia like a self, and additional bone grafts were kept so that the healthy bone graft won't get resolved later. And for the support of this fusion, we also had inserted distal syndesmotic screw, but well above the syndesmosis. And to correct the deformity in a so we applied medial distal tibia hemiepiphysiodesis with a screw for the temporary purpose. So in the result, in early post-op period, the biopsy showed, as expected, the tissue was consistent with the hematoma, which was likely to get, the bone graft was likely to get resolved if it was kept there. So we, once the bone graft showed integration, we allowed full weight bearing on the cast, and we found that at the 4 months follow-up, the graft had already fused with the tibia. So, and gradual improvement of the angulus valgus was noted. So this the lateral distal tibial angle, which is 73 degree, it was normalized by 1 year till 90 degree, and no resorption of the graft was seen. So at 16-month follow-up, the angle valgus was corrected till the normal values. There is no restriction of the joint movement, ankle movement, and there is no any pain or limitation of the activities. We kept the screw for additional 2 to 3 months, so that there is a slight overcorrection, so that we can avoid recurrence of the ankle valgus. And you can appreciate there is complete fusion of the tibia and fibula, and there is no resorption of the graft. And then so the wedging, even the wedging has been corrected. The distal tibia lateral aspect, the talar dome now appears parallel to the floor. So, so we remove this graft, we remove this implant after the full correction was achieved. So this technique, looking back to the literature, so this congenital pseudoarthritis of tibia, even it is rarer, but the deformity is less severe when compared to the tibia. Pseudoarthritis are often associated in 60 to 90% cases. It is associated with the congenital pseudoarthritis of tibia and neurofibromatosis 1. Kids can present at various ages. There are various case series by Choi et al., where the mean age of presentation was 3.9 years, and it is 7.6 years by Martus and Johnson. Deformity was also variable based on the gap. The more the gap, there was higher deformity. This was reported by Bijlani. And the restoration of fibular continuity and distal tibial fusion was applied in various cases, in various series by Yang et al. And Cho et al. The Cho et al., he did both the strategy of distal excision of the pseudoarthrosis and also osteosynthesis of the fibula, and the results were variable. There are 2 cases of recurrence out of 13 cases. Similarly, Lambasi did the Langen scale procedure, where he excised the fibula and the valgus deformity was corrected in 7 cases with the fusion of the distal tibia and fibula. So looking at the literature in our case experience, so what we can conclude is, before making a treatment strategy for this case, you have to look at the age, what is the rapidity and severity of the progress of the deformity, what is the status of the distal fibula. Has it gone to the pseudoarthrosis, or is it just tapered? What is the state of the distal physis? If the case presents late, maybe after 11 years, there is less chance that we can get full correction of deformity by hemiepiphysiodesis. So considering these cases, to stabilize the ankle to prevent the recurrence, the distal tibia fibular fusion seems to be a good option and has been tried by various authors. And there are various authors have also tried fibular osteosynthesis to prevent the recurrence of the deformity, but the results were variable. Some had resorption, some had non-resorption. So to correct the deformity based upon the age, the child is older age, after 11 or 12 years, the growth modulation might not work. So in those cases, malleolar varicization of the tibia should be done. And whenever there is enough growth remaining, the growth modulation can be done. So talking about the growth modulation in the distal tibia, both a plate or temporary epiphyseal, hemiepiphyseal disease with this screw can be done. So the results are good, and there is less permanent deformity by the use of screw, as reported by Dr. Anil Agarwal. So the screw hemiepiphyseal disease seems to be a good option for these cases. So thank you for the.
Thank you. Thank you, Dr. Nitish, for a simple solution for a difficult case, and age-old angle-scaled procedure, which has brought out an excellent outcome in this particular case.
Thank you, sir.
Now, my question is, how far you resect proximally? How do you decide that this much to be resected?
Yeah. First, we follow the soft tissue plane. Before going to the bone proper, we follow the soft tissue plane.
So there will be fibrous in there, so fibrous tissue exercise. So you till you reach the bone, or how much? How do you decide
we
that
follow
this
the
endpoint?
Yeah, first we see the soft tissue plane. The pseudoarthrotic segment, hematomous tissue, is slightly yellowish, and the texture is different when compared to the normal tissue. So we follow till the normal tissue comes, soft tissue. Then we go to the bone, and we drill the bone. The bone is bleeding properly, and there is no any tapering at that region. There is no sclerotic within the medullary canal. We excise till that segment. In distal segment, we had to do under excision, because if we go more distally, then we might reach the physis. So in distal region, we kept some portion of the metaphysis.
Okay. So you open up the medullary canal as well?
Yeah, we open the medullary canal.
Right. Okay. Yeah. Over to Dr. Ankit. Yeah.
Great case, Dr. Nitish. I mean, I must congratulate you on the way you've managed it so well. And ankle valgus in such situations like you have presented in pseudoarthrosis fibula is akin to presentations that are seen with fibular hemimelia as well. So in early grades of fibular hemimelia, the presentations are very similar, and I have some experience of managing fibular hemimelias who have presented with this, with such a situation. So a couple of things that I want to ask you is, did the child have any limb length discrepancy as well, other than the deformity?
At presentation, the child had limb length discrepancy of 1 centimeter, and the discrepancy didn't increase after the hemiepiphyseal disease.
And the age of the child was at presentation was
5 years at presentation. 5 years, 3 months might be at the surgery, and by 7 years almost the last follow-up.
So if you can just hold this slide that you have, right now. The only thing that I, tend to slightly differ on in the way that you manage this, that the level of the fibula is slightly higher than what it normally should be. So on the X-ray on the left, the one that, in which the procedure has been done, you see that the tip of the fibula is at the same level as the tip of the medial malleus. Yeah. So what can happen, when you leave it at that level is the hind foot or the subtalar joint can, later on progress into valgus. So that can lead to sort of a recurrence. The only thing that I would differ is probably push down on my fibula slightly more down. So as to, in adults,
this is not the final follow-up. This one is the final follow-up.
So even in this,
down.
Even in a final follow-up, the idea is...
So station 0 and 1 is normal for the children.
The idea is that the talocrural angle will dictate the amount of fibula length that should be achieved, one. And in a child, the physis of the fibula should lie at the level of the dome of the talus. So those are the two ways that you can determine as to where the fibula should lie, because the fibular physis is not at the level of tibial physis. It has to be slightly more distal. I mean, great case, amazingly done. But that is one thing that, you can slightly improve upon. The other thing is, there is also corneal plane bowing or deformity. Do you think that is going to affect the outcome long term, or anything that can be done for that?
In children, the deformity in the sagittal plane, that is likely that gets remodeled.
Sorry, sagittal.
Yeah.
Okay, you feel that will get remodeled.
Yeah.
Okay, and there is literature to support that as well, I believe.
Literature to support that. And about this Malhotra grade of this distal fibular station, we've done a study, quite long series in Chachaneri Hospital to know the normal station. So 0 and station 1, and that is up to the level of the distal epiphysis. It is considered normal because they have less chances of recurrence. This is a study. The study has been done based upon the fibular bone graft harvesting for various purposes.
Okay, great. I mean, very well done, and I think amazing result as well. Congratulations.
Did you do epiphyseal disease of the tibia by that screw?
Hemiepiphyseal disease, sir.
Hemiepiphyseal disease.
Hemiepiphyseal in the medial side.
Okay. Normally, at what age you should address this? Any particular age, or you just to?
No, there are based on the classification, there is a dual classification which says whether there is progressive angle valgus or not, and whether the fibula is already gone into pseudoarthrosis. So already pseudoarthrosis, the deformity is progressive, and the child is having some discomfort, then we should address, because there's no point waiting, because the secondary changes happens in distal tibia as well, and talus continues to shift laterally and tilts laterally, so it is going to affect later.
Yeah. And as Dr. Ankit was pointing out, with this hemiepiphyseal disease and this fusion, it will affect the length of that leg eventually, isn't it?
Yeah, the length, it's per se because of this pseudoarthrosis can be there, limb length discrepancy, but in children, if there is more than 3 centimeters, then we can do again epiphyseal to equalize the limb length later, if there is discrepancy.
On the contralateral side.
On the unaffected
contralateral,
side.
yeah.
Contralateral side, okay. So that you decide at what age?
That we decide later. So during the development, if the
second growth spurt,
yeah,
somewhere around that
if
time.
the discrepancy is more than 3 centimeter, so we don't, there is no point of waiting when there is limb length discrepancy more than 3 centimeter. Before that, we can do apply the Surgeries, and if it is progressive into successive visits, then we decide for limb length equalization. That calculation is we do by the Pallet technique. There is a multiplier method. So what is the limb length discrepancy that is going to happen at skeletal maturity? We calculate that. If it is well more than 5 centimeter, then we intervene even earlier.
I see. And after this epiphyseal disease and this Langenskill procedure, how long the patient remains non-weight bearing, or you allow weight bearing?
We allowed weight bearing after 4 weeks after this procedure, because the only thing that was for us was to integration of the bone graft. So we allowed after 4 weeks with the cast on. So in the next visit after again 4 weeks, once the bone graft was integrated, we removed the cast and allowed child to walk on. The only concern for is now whether there will be recurrence again or not. So that is a concern for us again.
So if there is a recurrence again, then what do you do?
So again, if the recurrence happens very late so then in that time we can do osteotomy. If it happens earlier, then again we can do hemiepiphyseal.
Excellent case. Thank you for presenting.
Thank you very much.
Any other questions, Deepak?
No, sir. No. Nitish, you have any questions? A lot of in our institute.
Presenting the case. It's a very nice case. I just have one doubt. So did you check the position of the ankle while fixing the tibia and the fibula intraoperatively? So did you dorsiflex it completely?
Yeah, we did the dorsiflexion, but since the distal third of the fibula is already excised, I don't think it's going to make much changes, because the distal tibia fibula is not so well fused before at the time of the surgery. It is going to fuse few months later, so few weeks later. So, but even then, considering the principle, we did the dorsiflexion.
Okay.
So it's to widen the
full range of motion.
Yeah.
Okay.
I just have one doubt, sir, Mohanty sir.
Yeah.
So does this dorsiflexion matters in majority of the cases, or it's just a theoretical thing?
So in adults, when we are dorsiflexing the ankle syndesmosis fixation, there was a lot of controversy whether that is really needed or not. And what they found is that it does not really make much of a difference even if you dorsiflex it or you keep it in neutral. It should definitely not be plantar flexed, but dorsiflexion is not something that is really required when putting in the syndesmotic screw. The idea of the widest part of talus being in the front does not really hold that true. The correct idea is that the fibula should be reduced in the incisura. That is what matters. Dorsiflexion, all those things don't really matter as much as reduction of the fibula in the incisura.
Thank you.
Okay. Okay, thank you. Then could you stop sharing the screen?
Yeah, okay, sir.
Anything you wanted to show in this slide or?
No, sir.
Okay, okay. So thank you. We have just, little over the time. So thank you all the speakers and all the moderators, Dr. Ritwika, Dr. Nitish, Dr. Abhishek, Dr. Tarun, Dr. Nitish, Dev, and Dr. Ankit Khurana for joining today and making an excellent educational experience for all of us and for all the viewers as well. So we'll be holding again in 2 weeks' time the next session of controversy and consensus with 3 different subspecialties like arthroplasty, arthroscopy, and tumors. So we invite cases from other young orthopedic surgeons and moderator also. Please join us so that we learn from each other. And I thank Dr. Deepak Gautam for coordinating this with a lot of pains, getting everybody together on this platform. And also I thank Dr. Ashish Phadnis and Dr. Swapnil Keny being part of it. And we also thank OrthoTV, Dr. Neeraj Bijlani, Dr. Ashok, Shyam, for giving us the opportunity and platform to discuss these cases. And thank you, Poonam, for coordinating this. Over to Dr. Deepak to give closing remarks. Then you close this session.
Thank you all. It was an interesting session. All the 3 cases are very interesting.
Yeah.
Very
Today
interesting.
it was really
Very
interesting. Yeah.
Very interesting cases, and all were very peculiar in their own. So thank you all. Thank you, speakers. Thank you, moderators, for giving us the time this evening. We'll be again back on 12th June 2024 evening 8 p.m. with 3 different subspecialties. And I also urge all the young orthopedic surgeons to come up and present their cases. And your colleague, you can send a message to your colleague to present their cases if they have any interesting cases for the next session. Thank you all. Good evening.
Thank you, sir.
Thank you, sir.
Bye. Bye. Good night.
Night.
Good night.
Bye.
Poonam, you can close this session.
Thank you.